scientist over there that listen, dude, did you do an RNA-based panel? Again, this happens mostly with ALK or RET or ROS fusions. You will not get these mutations if you do only a DNA-based panel. So that's also very, very important to find out. Okay, please go ahead.
It's very unfortunate for the companies not to disclose that they are not doing testing for the RNA fusions. I believe when you're screening, NGS screening for lung cancer, you're supposed to screen for fusions. That's absolutely important, and if the people are not disclosing that, it's very unfortunate. I think we as a medical people, we should keep a check on that, especially in lung cancers.
We need to talk to the molecular pathologist and find out that ask them what exactly is happening around over there. Okay. So this patient underwent this. So again they have written, that's nice actually. These people are actually given number of genes covered is this, hotspot is this, CNV is this, fusion drivers is this. This is good. So this looks good. So this patient did not have any genes or fusions which was detected. Then this patient you sent to foundation medicine and you got an EGFR kinase domain duplication. So I'll ask my moderator only, ma'am, in simple Hindi or not Hindi, in simple English, what does this exactly supposed to mean, EGFR kinase domain duplication?
So is
it almost something like a lymphosarcoma of the intestine, which in that Rajesh Khanna movie they said over there? Is it something else or is it just to scare the medical oncologists away? Hindi में तो क्या है और English में?
Lymphosarcoma itself has become obsolete.
Yes. So has the EGFR kinase domain duplication also become obsolete?
I think it's becoming to the natural domain mutation testing. I think we'll have to start screening for this domain duplication as well in the near future. So it's basically a duplication of exon 18 to 25, and there is a constitutive activation of the pathway, and because of this, only effective and osimertinib is able to bind to that particular site. The rest of the drugs are not able to bind. So if you have started the patient with dactomacin early to liver, the response might not be that good. So it's best that if you have this domain duplication, afatinib and osimertinib is the best way to look forward at this particular type of duplication. So these are some of those graphs in which people have seen the response with erlotinib, afatinib and osimertinib, and they've saw a good response with afatinib and osimertinib. So that's the significance of this particular mutation.
So wait. Now I have a problem with I have a huge problem with these two reports. Why this EGFR domain kinase domain duplication was not picked up in the earlier NGS report, and why it has been picked up in the foundation medicine report? Is it? And second thing which I want to ask, and I always ask the molecular pathologist is molecular pathology an observer dependent procedure, or is molecular pathology a machine dependent procedure? So a CBC report which will be done by 1 or 2 will have 5% variations. If I have to give a AC Taxol to somebody, there will be only 5% variation. Surgery robotic skills will have a 20% variation. So what is molecular pathology? Is it an observer dependent? Dr. Amrit Kaler working in a Rajiv Gandhi lab, I hope it happens soon, or Amrit Kaler working in a foundation medicine. Is it a difference? Please tell us the answer. Why you didn't pick it up earlier?
Yeah, the first thing I would like to answer the first question. The first panel was not planned. It's a hybrid capture panel. So it did not cover this particular domain duplication. So that's why it was not picked up before. And you have to plan your panels. This is how you plan your molecular pathology. It's all about planning. It's all about how you look at the patient. It's all about not only about observing, but you see different patients and then you decide which is the more common mutation and which needs to be included in your panel. There are some panels which were designed 5 years back and they have not been updated. There are so many new mutations, variants which keep coming. And if it is amplicon based, okay, you might have a false positive, but if it is a hybrid capture, you design your sites, you know which all particular mutations you are going to pick it up. And if this particular is not there, if the panel does not have CNVs, if the panel has not been designed to pick up this, you will obviously miss it.
I have a question.
Yes, I thought so.
Yeah,
because this is supposed to, generate a lot of interest. Tell me that.
Because, kinase, what is the frequency of kinase domain mutation when you see the entire
It's very less.
So percentage, what is the chance if you are not looking for kinase domain mutation? What are in, say, suppose we are doing it for 100 people, how often we will miss this particular mutation?
I think
No, you can answer this and then, yeah, please say.
So basically, this kinase domain duplication is less than 1%, and less than 1% kinase domain. So most of the cases in lung cancer here in India never ever see kinase domain duplication. Never ever see kinase domain duplication.
So it's a rare thing.
It's
So
very
it's a very rare thing, and routinely, I mean, it's a chance we are discussing on a rare case. That's the way we should
I
understand.
will come to something else also.
1 in
Yes.
100.
No, it's less than 1 in 100 among EGFR positive patients. So suppose you have 30-40% EGFR mutation. This we may encounter when we see a lung panel for 500 patients. You may see one patient. So that is the frequency.
Fair
So
enough,
that
yes.
is the one thing, right? Then can we go back to 2 slides before that oncominumab?
So when would you suggest we do
2
it?
slides before.
One more. I will tell you, ma'am. I will tell you, ma'am.
One more.
Some suggestion is to it.
Yes.
I will tell you, ma'am.
Patient wins.
Let's look into this report.
Yes.
First line of the list of genes covered, hotspot mutation. They have mentioned hotspot mutation. So which means most of these genes only you are going to cover the certain regions of the gene, not the entire gene. Right? So that is the difference between the hotspot NGS versus amplicon based NGS and hybridization capture NGS. So when we are going for hotspot, we are going to part of the gene only, you are going to pick up the point mutation in those things. When it comes to the amplicon based technology, you are going to, it's put in the amplicon, it's put in the like amplification and all those things. Whereas the amplicon based technology can have the chances to miss out the bigger deletions and duplication. Bigger deletion and duplication, that's what exactly is happening over here. So it's amplicon based technology. So what you are scanning is for exon 18 to 25, the duplication, which is the bigger region. So that has the chances to miss out in the amplicon technology, whereas the hybridization capture technology can cover. Why the hybridization capture technology is picking up is that when you are designing the probes, we need to ensure all the labs can do the hybridization capture technology. But the probes they are used to by the hybridization capture technology, whether they cover those regions or not. That is the first question we need to answer. Right? Whether if they cover the exon intron 17 to exon 18, and then that side of it is the intron 26 towards the exon 25. Those regions were well covered. In between region, if it is well covered, more than 5 MB, then it has to capture by the hybridization capture technology.
Sure, but the point I was indirectly making by asking this question was, if you are doing an conventional 12-gene panel, which we routinely do for most of our patients due to financial reasons, we are not wrong in doing that. We will pick up more than 99 or at least 99% of EGFR mutation, and we will treat 99 out of 100 patients who will benefit from an EGFR TKI. That is the point I was indirectly trying to make,
No.
but I have made that point very politely.
So even
You
if
don't
are
even
taking
write that
the-
down. So I'll tell you, yes, you have a point, and I'll come to your business. Yes, you have a point. Ma'am, first him and then you. Okay, go ahead, ma'am. Please go ahead.
I was actually we covered most of the things. Just one more thing I wanted to add in the panel is that you rightly pointed out it's a hotspot panel. So in hybrid capture, we will also go for the complete exon scanning. So whenever the disclaimer, the methodology, what you are looking into a report, it's very important. Whether it is targeted hotspot panel or is it a complete panel, what exons are covered. So if it is spanning the intron exon junction, you would have been able to pick it up. But as you said rightly, if we are talking about the most common mutations, these are large instances where these are already
Correct. My next question is going to be, when do you order that also? Please go ahead. Yes.
I have slightly different opinion about this.
Fantastic.
In this panel, we have all those
At least we have been able to make people wake up in the morning. Please go ahead. That is what we are getting paid for here.
all the exons are, this 18 to 25 exons are covered in this panel. And when you do the amplicon-based sequencing, you should be able to capture this EGFR kinase domain duplication, provided you have proper analysis.
Okay.
So kinase domain duplication comes under the variants of the structural variants, like you spoke fusions. If you want to look for a fusion, you should do RNA sequencing. So what is the problem of detecting fusion from DNA sequencing is the analysis. So if we have an analysis pipeline properly, which has the ability to detect these large structural variants, they can pick it up. So now in Oncomind, what is happening, you sample in, report out. So they have been predefined for those variants, not for this, therefore they have missed it.
So that is why you should have a molecular tumor code. I mean, honestly, this is the reason why you should have a molecular tumor code, because then, yes sir, your point, please. And then Dr. Like
So we are talking things which are not practically done, sir. Most of the patients won't come to you directly. They will go to pulmonologist,
Correct.
and pulmonologist would take biopsy
Correct.
as small as possible for the fear of bleeding. And that specimen will not come to any of us or any of the labs which are accredited, NABP accredited, or they will go to local lab where the local pathologist will do everything possible on the
Correct.
earth, and the patient will come to us. And
Correct.
immediately, if we ask them to do all these things again,
they will run over to somebody else.
they will go to
Yes, sir.
somebody else.
This happens to us also.
And if we send to any accredited center, they will tell that there is hardly any tissue, we cannot do anything.
Correct, sir.
So, practically, from Indian standpoint, at least from
It happens Indian, sir, India, pan-India. Money is an issue pan-India, sir.
Yeah.
It happens everywhere.
I will support the pathologist at this point because you send the tissue to us, okay, lung mass. Now the lung mass came from lung, from liver, from kidney, from urinary bladder, from endometrium, from OVD. We have to confirm that and we have to put all those markers to give you a proper
EMR.
written diagnostic report. Yes, it is from the lung and we are not sorry about
So
it.
that is why you have to have a EMR where you find out the report. What she is saying is, at least write the history. I mean, normally what happens, pulmonologists write lung mass under evaluation. Sometimes they don't even write one lung, L1 written over there. I ask my resident, L lung hai, liver hai, lymph node, लिख तो दो कुछ. I mean, that's what I ask them. But your point is very well taken, sir.
instead of asking the patient to go ahead with the biopsy immediately, can, at least in low budget center, can we go ahead with chemotherapy, and after 4-5 cycles, the patient would have also got enough toxicity with chemotherapy, and if we suggest them that if you don't want to continue any more chemotherapy, you go for this biopsy and this test.
So there is a problem with that, sir. The moment you give a platinum-based chemotherapy, DNA attacks get formed. Then getting a DNA out of that is another issue. So whilst I agree with you that it's a problem, my suggestion to you would be to educate the pulmonologist, get the pulmonologist, get the interventional radiologist, talk to them, get them to molecular tumor board. That's what we did. For the last 10 years, I have been running a thoracic tumor board, sir. It was difficult initially. Everybody used to say, the pulmonologist say, "Arey, we get enough tissue." The molecular, they don't get any tissue. I asked the molecular pathologist to get me a data about how many times they have to return the sample. We got our clinicians, my students got an idea about how many ILCs they are putting. I put the data in front of them fair and square. Okay, listen, this is the data. Your one biopsy in 40% of time you have to get a repeat biopsy. So because it's an in-house thing, administration was also there, it was easy. But sir, I think we need to move on. I mean, giving chemotherapy to everyone, I will respectfully disagree with you. Because, sir, very recent, not recent, very much in past, one of my patients died because of toxicity of pemvidexate tablet and some kind of nephrotoxicity. He did not even get a chance to get EGFR TKI. I felt very bad for him on that day, that at least maybe if I had convinced him enough and given a TKI, things would have been better. So right now, I do go ahead and give them first cycle of chemotherapy. But nobody gets second cycle of chemotherapy without getting an NGS report over there. So I do start. I also work in the corporate sector. I also have to look at my balance sheet over there, left, right and center. But I convince them that listen, I need a biopsy again and again. Now my pathologist sees over there, medical 5, Ullas, Batra, they said take 2 more issues, otherwise that mad guy will come in and talk to us. It is better to have that mad guy approach and get the tissue with the first one only. The second point which everybody was making was absolutely okay in sending a 12 gene panel. You will not miss out with 95% action injection. But now the world is moving towards FLORA2. Which patient will you want to have combination therapy? Which patient will you not want to have? We need to move on. We need to move on beyond that also. The money will come down for a broad-based NGS also. The point is, we need to get convinced. I remember Dr. Kumar Prabhas, when he initially came and said we are doing NGS for everyone. I used to laugh at him. I said, "Sir, kya baat kar rahe ho? It is not going to work out." Today, we do NGS even for squamous cell cancer, and we do a 34G panel. The more and more NGS you do, the more and more the cost of that panel also will come down. See, today the 12 panel NGS is costing 8,000 rupees. If you send everybody for that NGS, the cost of a 35-54 gene panel also will come down to 20,000 rupees. And we will do a much better job for our patients. That's my submission. Agree, it's a rare case, but then we need to sell the science first. If the medical oncologist is convinced that listen, this patient may get a different treatment, this may get a different treatment, then we'll go. Important thing, Dr. Amita, before I come to you is what you rightly said. You know, you need to understand that all NGSs are not created equal. You need to talk to them. Talk to the molecular pathologists, get them to the picture and say, boss, aisa kyun hua? I asked this question to her. We are good friends. We are sitting over there. But when you come over here, we said, why did that not pick up and why did this not pick up? Next time, I'll make sure he, and so where I do repeat, I told her also, if it's a non-smoker, I want a 12 gene panel, 34 gene panel, the patient is not responding, I have something coming up in my mind. I'll be more keen in sending this patient for a higher base panel if they can afford. If they can't afford, I can't do anything about it. I'll go ahead and give my standard chemotherapy. If it's a smoker, my thing will be okay, fine, for variety it may not be there, it may shall be there. Finance just play a major role. So non-smoker, we do a 34 gene panel, start them on chemotherapy, something comes positive, fine, nothing comes positive, I do make a point in pass that listen, we can do a bigger panel also, you want to do, otherwise take 3 more cycles of chemotherapy, we'll see later. Do a liquid biopsy as you were telling at that time. Yes, ma'am.
You're very right approach. Regarding the tissue, I have one more suggestion. What we do sometimes is the problem happens when we have the small biopsies being sent to us. So my department, molecular pathology and histopathology, we always divide the fragments. 3 for histopathology, 3 for us. So that way we are able to say our block from getting exhausted from the number of ISCs.
And correct me if I am wrong also, since if you have the molecular pathology and histopathology same lab, what we do is, we tell our pathologists only now say that the block with the highest tumor cellularity content goes to the molecular pathologist. With a normal content, because it's only an IHC, you don't require that. That goes for a PDL1 alkaline IHC. So 5 years back, we sat with our lung pathologist, molecular pathologist, listen, this is what I want to do from you. Tell me a solution. I said, I don't know. How do I know what is supposed to be done? You don't know all these things. Because they also want to go to conferences and boast, no? It's not only me who will want to come to Kumara come and go to a back bottom. They also want to go. Now we have a data thing. Now our pathologists, 85 to 90% chances that we will not have to repeat a biopsy. ISCs only 2, maximum 4. Otherwise it's NOS. Life has become very, very comfortable. Yes, we do miss on 1 or 2 patients like this. It is okay. But like you said, we don't miss out on 98% of patients. You have an EMR. It's a lung mass showing. Even yesterday we had a patient of pleural effusion and biopsy was on adenocarcinoma, but it was showing Samoma bodies, female, no adnexal mass. They still went ahead and did a PAC-6, came as positive. I again spoke to them. I said there is a mixing up. We did a repeat biopsy. So the pathologist has to keep their eyes open. The medical oncologist also keep his eyes open and discuss with the pathologist. Is that the right statement to make? And then only the patient will keep their eyes closed and trust you.
Sure.
That is what they will do.
History is very, very important. So I'll just move on to the next slide. It says that the EGFR mutations are very common in the Asian population and the KRAS 12C is seen to be common in the Western population. So this was some statistics which I saw on the net, and then I divided the papers which has come out, including Dr. Batra's paper from North India, and then from the Tata we had some papers and which concluded that Western India had a higher population of EGFR mutations and South Indians as well, but it is slightly lesser in Northern India based on all the papers which came out in the last 10 years. So let's look at the case. We can finish half an hour in the first case only. So the second case is 61-year-old male with a persistent cognitive weight loss, lung cancer, with a persistent left nomination diagnosis. In pathology, we had an infiltrative cytoplasm arranging nests with a fibrotic stroma. Cells had abundant eosinophilic cytoplasm with showing pleomorphism, necrosis, and lymphocytic infiltration was seen. So IHC seems to be positive. So I wanted to just highlight how important it is to understand tumor microenvironment. So what we see under the microscope on the slide is tumor cells which are arranged in nets, or they can be fully differentiated, or they can be in acinar pattern, or they can be in the papillary form or the crimpary form pattern, but also there are present a lot of lymphocytes, inflammatory infiltrate, which can be in the form of lymphocytes, plasma cells, or even eosinophils, neutrophils. Sometimes necrosis is seen, sometimes the fibrosis is seen. So all of this tumor microenvironment actually modify how the tumor behaves. So this is a huge, research which was going on the TILS therapy, that if the patient has the lymphocytes inside the tumor cells, which is a stromal TILS, and the ones which are in the periphery, so those lymphocytes has a more prognostic effect